Good afternoon, everyone. I'm Dana Corson, a media officer with the National Academies of Sciences, Engineering, and Medicine. Thank you for joining us this afternoon for a webinar on the report that was released just last week titled Opportunities for Organ Donor Intervention Research, Saving Lives by Increasing the Quality and Quantity of Organs for Transplantation. If you haven't gotten to read it yet, you can download a copy of the report and other supporting materials at www.nationalacademies.org/organ donor research. And you can follow the conversation about the report on social media at #OrganDonorResearch. For those of you not familiar with the U.S. National Academies of Sciences, Engineering, and Medicine, we are private nonprofit institutions that provide independent, objective analysis and advice to the U.S. to solve complex problems and inform public policy decisions related to science, technology, and medicine. The National Academies operate under a congressional charter to the National Academy of Sciences that was signed by President Lincoln in 1863. For each requested study, panel members are chosen for their expertise and experience and serve pro bono to carry out the study's statement of task. The reports that result from the study represent the consensus view of the committee and must undergo external peer review before they are released, as did this report. I have with me several members of the committee to discuss the report's findings and recommendations. But before I introduce the committee, I want to go over a few technical reminders. After the opening remarks, we will begin to take questions through the Q&A box located in the right-hand corner of your screen. Simply type your question in the box at any time and click Submit. We ask that you leave the box set to send your questions to all panelists and that you identify yourself and your organization when asking a question. If you have any technical issues during this webinar, please contact WebEx Technical Support at 1-866-229-3239. And now I'd like to introduce the members of the committee who are here with us today. First, we have Dr. James Childress, who is chair of the committee. He's University Professor and John Allen Hollingsworth Professor of Ethics Emeritus at the University of Virginia. Next is Dr. William Marks, retired Robert B. McMillan Chair and Chief of Organ Transplantation at the Laboratory for Transplantation Biology at the Swedish Medical Center in Seattle. We have Dr. Lainey Friedman Ross, Carolyn and Matthew Buxbaum Professor of Clinical Ethics and Professor in the Departments of Pediatrics, Medicine, and Surgery at the University of Chicago. And lastly, we have Dr. James Young, Professor of Medicine and Executive Dean at the Cleveland Clinic Lerner College of Medicine at Case Western Reserve University. We'll start off with a presentation summarizing the report by Dr. Childress, and then we'll open it up for any questions you may have. Please note that this briefing is scheduled to last 1 hour unless we run out of questions beforehand. And with that, I will turn it over to Dr. Childress.
Thank you very much, Dana, and thank all of you for joining us for this webinar. I will go through the slides fairly quickly, and then we'll turn to members of the committee to elaborate, clarify, augment in whatever ways they choose, and then we will look forward to addressing your questions. We have the list of all the committee members in the next slide, and including the ones who were introduced today. And then the next slide gives the study sponsors, and we thank them for requesting and supporting this study. The next slide provides the abridged statement of task. The full statement of task appears on page 4 of the report. This ad hoc study was intended to examine the ethical, policy, regulatory, and organizational issues relevant to the conduct of research involving deceased organ donors, what we're calling here organ donor intervention research. The committee was asked to examine the gaps, barriers, and opportunities for clinical research involving deceased donors with the aim to increase the quality and quantity of donated organs available for transplantation. And then I'll come back to the last part of that sentence later. Next slide, please. The study timeline indicates that we started just over a year ago and then finished the report over the summer with revisions in response to outside reviews, and then finally public release, as Dana mentioned last week. But why focus on organ donor intervention research now? Next slide, please. Well, the following slide indicates the first of the reasons. There's a huge gap that remains between the number of people on the waiting list for transplantation and the number of organs available and the number of organs transplanted in a given year. This slide gives the waiting list registration by year. When we were doing the report, say in mid-July, there were over 117,000 people on the waiting list for organs at that time. But in 2016, there were 27,630 organs from deceased donors and close to 6,000 more from living donors for a total of 33,600 approximately. So there's that huge gap that remains between the need for organs for transplantation and the transplants of organs to help save lives and improve their quality. The next slide, please, focuses on another issue that arises, that even among the organs donated, many of them are not usable in research. In 2016, almost 5,000 were discarded because they were not usable for research. The next slide indicates that a number of organs that are obtained, and in some cases with a goal for transplantation, end up not being discarded, but rather used for research purposes. And the big question arises whether some of those could be made usable for transplantation with following appropriate kind of research. So in this context, the goals of organ donor intervention research are to reduce organ shortage, to upgrade the quality of organs, to increase the number of transplantable organs, and to improve transplant outcomes. But there are challenges. The next slide, please. The next slide, please. These challenges can be divided into two major sets. The first set has to do with challenges across all fields of clinical research. Trials in multi-sites, hard to differentiate sometimes between quality improvement studies and research studies, the need to implement the appropriate levels of oversight and protections for human subjects, need to ensure that these subjects understand the risks, benefits, and alternatives so they can give informed consent or refusal, to the challenges in delineating a consensus on standards of practice, and of course, challenges regarding funding and resources. But those are challenges across the field. The next slide identifies some of the challenges unique to organ donor intervention research. And these challenges have to do, first of all, with the multiple individuals involved. The research is conducted on organs in or removed from a deceased donor, but they are assessed in transplantation in recipients. Again, as we'll emphasize throughout, who may be in different and even distant locations. Non-target organ recipients, I'll come back and explain that in a moment. It's unknown at the outset of the research who will be involved in the research study. There are numerous potential recipients, given the waiting list that I mentioned to you, as well as a number of different parties involved in this whole process. And yet there's a need for rapid decision-making on the part of the transplant program and the potential individual recipient. All this while there's a movement toward a more national approach in the allocation of organs from local and regional, further increasing the possibility of distant locations from where the organs are obtained initially and on which intervention research may be conducted. And then there may be a tension between the guidelines for research and the guidelines for allocation in some cases that may create difficulties. So those are some of the challenges. The next slide focuses on the way we wrestled with some of the important terminology. Emphasize again that this is research that is conducted on organs while they are still inside or have been removed from the body of a deceased donor. And that determination of death may have been made by neurological standards, and that will be most common, or by circulatory standards. Another important distinction that I mentioned earlier is involves non-target organs in relation to target organs. Target organs refer to the organs targeted by the research intervention in an effort to improve that organ's viability for transplantation. But if the research is done on that organ within the dead donor's body, then that research could have an impact on other organs that will be transplanted, but they're not the intended target of the particular research intervention. And so research on a kidney and a deceased donor may have an impact on other organs that might be transplanted. So that becomes an important issue in thinking about these topics. The next distinction that we focused on in terminology, next slide please, relates to authorization versus consent. You will hear in public discussions or see in literature and public policies a variety of terms for the decision to transfer organs from a deceased person for various purposes, transplantation, research, and so forth. We have chosen, even though the terms listed in that first paragraph are all appropriate in some context, we have chosen to give priority to the term authorization for purposes of clarity. This refers to the decedent's prior decision to donate his or her organs or to the surrogate's decision to do so in the absence of a decedent's prior decision. And we reserve consent in this report then to refer mainly to decisions related to participation in research. Next slide, please. Then the next slide. Turning now to the overview, we considered relevant ethical principles as is part of our overall task. We identified some that are relevant to both organ donation and transplantation on the one hand, and to research involving human subjects on the other. For instance, research involving respect for persons, beneficence, and fairness. And validity, the fourth one listed on in this slide, refers to the generation of evidence sufficient and reliable to guide decision-making in the context of research. And then one that the committee stressed a lot that applies to both organ donation and transplantation and to research involving human subjects is trustworthiness. The committee emphasized the need for trustworthy systems of organ donation, transplantation, and research involving human participants in order to create and sustain public trust. The public's trust is a precondition of the public's willingness to donate organs and to participate in research. The next slide gives the overall goals that we considered in this report, 6 of them. Rather than going through those goals at this point in a summary fashion, I will discuss each goal in relation to the recommendation that is designed to indicate how we can reach that particular goal. Next slide, please. So the first goal is to improve transparency and public trust in the organ donation process for research followed by transplantation. So this recommendation calls on several bodies involved in educating the general public and obtaining individual and surrogate authorization for the use of organs to explore, develop, and test communication strategies and materials that explain organ donor intervention research, and then to implement and disseminate these resources, at least the ones for which effective messaging has been identified. And these should include template language for all organ donor registries to use, templates for departments of motor vehicles and organ procurement organizations and others to use in communicating information about organ donor intervention research, and standardized talking points for OPOs to use in communicating with donor surrogates and families. Next slide, please. Goal number 2 is to improve the coordination and sharing of information about donor preferences. And this recommendation calls on all active donor registers in the U.S. to coordinate in order to ensure a single, unified, secure national donor registry that's easily accessible to OPOs, organ procurement organizations, and that automatically incorporates organ donor registry collected by departments of motor vehicles into this single national registry. And the further part of the recommendation is that model state legislation would be useful to facilitate this merger. Next slide, please. This takes us to goal number 3, which is to clarify legal guidance on organ donation for the purpose of research followed by transplantation, that is, organ donor intervention research, what we're talking about in this report. This recommendation calls on the National Conference of Commissioners on Uniform State Laws to explore revisions to the Uniform Anatomical Gift Act that would clarify the authorization of organ donation for purposes of this kind of research followed by transplantation. And this part of the recommendation indicates that it would be useful to clarify when a decedent has stated a general intent to make an anatomical gift, that is, has indicated a willingness to become an organ donor without any further specification, then research followed by transplantation is permitted. Second clarification is that the committee recommends that OPOs should be explicitly empowered to seek from a donor surrogate the expansion of the authorization for an existing gift for any purpose that the authorization given by the individual or by the surrogate to include research followed by transplantation. Next slide, please, gives the continuation of this third goal and the third recommendation. There were 2 options the committee considered for resolving ambiguities in the UAGA and state laws. But because of the sensitivity related to trust and transparency, the committee felt that this issue, these 2 options, required more public consultation and therefore recommended that the OPTN, the Organ Procurement and Transplantation Network, and the transplant community engage in public consultation to determine how the public feels about these issues and determine then whether to recommend amending the Uniform Anatomical Gift Act and state laws to specify that when the decedent is authorized transplantation, this denotes that the gift is authorized for research followed by transplantation, or to specify that research followed by transplantation is one of the purposes in the list of choices that the donor may select for purposes of becoming an organ donor. Next slide, please. The fourth goal is to promote informed consent for transplant recipients' participation in organ donor intervention research. So we're turning to the transplant recipients now rather than the donors of the organs themselves that are used in the research. We're looking now at the transplant recipients' participation in organ donor intervention research, and to promote informed consent in a way that is compatible with the logistical complexities of organ transplantation. Of course, again, the need to transplant organs very quickly, and this is complicated further by the fact, as I mentioned before, that donor and recipient are often in different and frequently quite distant locations. In this recommendation, we call on appropriate bodies in collaboration to develop and implement a protocol for notifying and educating potential organ transplant recipients about the possibility of being offered an organ that has been exposed to a research intervention, and then seeking informed consent if they agree to be part of the research study. So there's further detail about this, and I'll just make a few summary comments from the recommendation that you'll see in the report itself. So the committee recommends a two-stage process of disclosing information to potential transplant recipients. The first stage would consist of informing potential recipients at the time of intake or listing about the possibility that research organs that have been subjected to interventional research might be offered to them at some point, and the levels of risk generally associated with such organs, as well as the risk of declining to an offer of a research organ. At that stage, and then periodically, potential transplant recipients can indicate whether they'd be willing to consider a research organ if offered. If they decline to do so, then they will not be notified when a particular research organ becomes available. But those who have agreed to consider such organs will be notified when a research organ becomes available and will be informed about its risk level and will be taken through a process of informed consent or refusal. This process may vary depending on what the single IRB that we recommend later in the report has to say about the appropriate consent for this research. The single IRB, if it determines that this is minimal risk research, may well alter or even waive the requirement of informed consent. That is something that the single IRB would need to do in relation to a particular protocol. The next slide lays this out in a schematic way, and I'll not say much about this at this point. It, in effect, summarizes what has gone into this to the slides to this point. And it's something you may want to come back to in your questions and have us elaborate even more. This is a schematic presentation of what we tried to accomplish in our analysis and in our recommendations. The next slide, please. Goal number 5 is to establish centralized management oversight of organ donor intervention research in order to ensure equitable, transparent, and high-quality research. So in this recommendation, the committee calls on the OPTN and several other organizations to establish and then sustain a standing donor research oversight committee, DROC, that can guide, coordinate, evaluate, prioritize, and disseminate research on deceased organ donor interventions. And this is one of two structures that we recommend, and a DROC should include an administrative structure to establish an independent, or more than that if needed, independent data and safety monitoring boards to ensure the scientific integrity of the research and to assess risk and benefits as the studies progress. And as I've already suggested in earlier comments, a single IRB should be established or contracted with to ensure that human subjects research protections for donor intervention research, to ensure those protections for donor intervention research studies. So 3 independent but affiliated and cooperative structures. The last goal, and we're almost at the end of my summary, is to promote transparency regarding organ donor intervention research and to enable the implementation, tracking, and analysis of organ donor intervention research and to improve transplantation outcomes. And so this recommendation calls on DROC in cooperation with several other organizations to create organ donor intervention research electronic tools to ensure that organ donor intervention research studies are listed on a publicly available website, that clinicians have the information they need to provide to potential recipients, that researchers can conduct their studies effectively, and that research outcomes are tracked and monitored appropriately, as well as that research outcomes are widely available in aggregate. And then we'll go into offer some further details about that. Well, I thank you for your attention during this summary, and I'd like now to open this to the three members of the committee who are with us today to clarify, elaborate, augment this summary in whatever ways they choose. Lainey, would you like to go first?
Sure. I think the important factors from our perspective is that doing research on these organs is really important, because we really do want to both increase the number and increase the viabilities of these organs, and the only way to do that is going to be both with research and with quality improvement. And so, we hope that, the community takes this as a sign that we really support the activities that they've been struggling because of other obstacles, and hope that this will help facilitate getting that to move ahead.
Jim, would you like to add anything?
Yes, to me, this is an extension of what has been occurring over really the last 25 years plus in organ transplantation, with the groups of professionals coming together to develop distribution schemes with UNOS, for example, and our OPTN. We have reached a point where the supply of organs has become static, at least in North America, and by endorsing, I think, this next move, we can help both improve quality and numbers of solid organs for transplantation across the different systems. So this was an exciting opportunity to come up with some thoughts and some recommendations, being sensitive to the challenges that the OPOs have, as well as donors, donor families, and then as well as recipients.
Bill, anything you'd like to add?
I just would say that I agree with everything that was said beforehand, and thank you, Jim, for an excellent summary. The only thing I'd add is sort of a little increased emphasis or an extension of what Jim just said, and that the committee clearly recognizes this is a huge challenge for the transplant donation community. That's just implicit in the report. And want to emphasize, and we did emphasize in the report, again, that because of the number of interested parties, this is going to require, a well thought out system of central management, and that management system is also going to require some significant, potentially innovative tools with which to effectively manage the enterprise. We recognize how complex it is, but I think our conclusion was that it is addressable, and we hope that we've helped with that process.
Thank you. All right, Dana, I think we are ready for questions.
Sure, yes. Thank you for your presentation and everyone for your comments. For those tuning in, please go ahead and submit your questions in the Q&A box on the lower right-hand corner of your screen. I'll just get us started off with, can you explain a bit more how the two-stage consent process would work? Could that lead transplant candidates to feel that they need to accept research organs in order to avoid delays in receiving a transplant?
Lenny, would you start with that one?
Sure. So the thought was when patients first come in to get worked up to be put on the wait list, they get a lot of information, but they also a lot of the options are fully delineated, including whether this is in the old language we used to call expanded criteria donor, whether they're organs that are at increased risk, and so there's a lot of education in the types of organs and the benefits and the risks of taking any organ. And we want this to be sort of incorporated at that point so that people understand that hopefully that lots of research is going to be being done because we really need to maximize the use of the gift. And so by bringing it up at this point when they're relatively healthy, it's a less stressful environment because it's during a whole day workup process. And by mentioning it now and sort of getting them on board to be able to ask questions and even, you know, to be able to talk with family members and things of that sort. And all we want at that point is a yes or a no, I'm willing to consider it. Because if they're willing to consider it, then when an organ becomes available, there's going to be a second conversation. So that's what we meant by two-step. And when the organ becomes available, now it's more of a time crunch. And now we have to say whether you're going to accept it or not. And so we want them to have had some opportunity to think about it. Oftentimes they come back from any checkups. And so during those checkups, they can readdress these issues if they have questions. But at the time that the organ is offered, we're going to have to give them enough information so that they understand what it means that this organ was, quote, researched, and then have to make the decision whether to accept it or not. Now, if at the first stage they had said no, they would never be seeing these organs. And so they need to understand that. They need to understand they can change their mind. They can be offered a research organ and say no. They can, at a regular visit, they can change from, I said I never wanted to see a researched organ. I now understand that there are different risk levels with different organs. I'm willing to consider some, but not all. And once they say yes, they'll be invited at a second stage when an organ becomes available.
Jim or Bill, do you want to add anything?
This is Jim Young. I think one issue are these conversations that we have with individuals who are our patients and going on to waiting lists, and it just behooves us all to be careful about the issue of persuasion or coercion or other things that we try to avoid during these conversations. And I think that by explicitly outlining a two-stage process, that this will be very helpful in getting patients to understand exactly what we are doing and not to have it perceived as being pushed into one direction or another.
Right. And this is Bill Marks. And adding on to that, we also have an appreciation that this may not be necessarily easy for a patient to make a binary response. I want in or I want out, or for that matter, for the center taking care of that patient who may or may not be very familiar with the research that they're talking about, as being, yes, this is a protocol that I want my patient under those circumstances to participate in or not. And so, some of the issues that need to be considered are, how do you make it during that second stage especially, and maybe even during the first stage, how do you assess a patient's personal tolerance for participation? What is their concern about their own safety after a transplantation? And to that degree, we as clinicians frequently speak about this rather batch type spectrum of risk, going from this is potentially has a high probability of or a higher than we would like probability, or perhaps you would like probability of causing you an outcome that you could be concerned about, or this is really a very, very low kind of probability, or there's no probability of risk from our point of view clinically to you. And so being able to provide a patient with that spectrum of consideration may take away that binary, the need to make a binary response, but it does then place on the transplant and donation community the need to somehow define those batches amongst themselves, those batches of risk, so that they can communicate to a patient and ask, what is their personal risk tolerance for harm in accepting an organ. So they may then be in for some organs, but not necessarily the others.
Thanks to all three of you. So Dana, we're ready for other questions.
That. Sure. Next question is, how and when are recipients of research organs considered human research subjects? What concerns did the committee have about informed consent?
Lainey, do you want to start?
That was a three-part question. Can you repeat it?
Sure. How and when are recipients of research organs considered human research subjects? And what concerns did the committee have about informed consent?
Right. So I'm going to start with the second question. So, informed consent is difficult at the second stage when an organ is being offered because of the time constraints. And so we were very cognizant of that, and that's why we really developed the two-step process, because we thought it was so important for them to have the time to think about what risks are they willing to tolerate. And again, remember that when I say risk, it's also there's a high potential for benefit as well, and so they have to decide in their own mind what type of risks and benefits and what are the alternatives, including the alternative not to participate. So clearly informed consent was very important. We also realized because of the time constraints, so as Bill was mentioning, rather than trying to bucket how we perceive these risks, whether they would be considered as minimal to no risk, whether they'd be considered slightly more than minimal risk, to try to help individuals in this time-constrained environment to be able to make an informed decision. So that was where the concept of informed consent. And the first question is, what makes someone a human subject? We really used the guidelines for the federal regulations for human subjects protection, which says that to be a research participant, first of all, you have to be a living subject. So the research that's being done on the organs on the decedent doesn't actually meet the criteria for human subjects protections under the federal regulations. We still felt that it was important to inform families that it was being done, and that particularly that we wanted this modification at the level of the of guidance of whether we have whether transplant means research followed by transplant, or whether we needed an extra box at the DMV in order for people to be able to give first-person authorization. And so so decedents are not research subjects per se, and yet we still, from a trust perspective and a respect for persons, we felt it important to inform them. It's the recipients who are the human subjects, and they need to be giving their consent for participation. I think those were the questions. Jim, do you have anything to add?
I have Jim or Bill, anything you want to add before we get to the next question?
I defer to Bill. I thought Lainey answered it quite nicely.
Yes, I did too.
So, Dana, we're ready for the next one.
Yep, next question. Could you expand on the oversight needed for this research? Why the need for more oversight, and what type of oversight is envisioned by the committee?
So, Bill and Jim, let you choose who goes first.
Sure. Well, maybe I'll just start out. Yeah, it's a great question. I mean, this is an extremely complex undertaking which has to address the needs of lots of stakeholders. And in order to coordinate and facilitate rapid communication between different groups, in order to establish enduring processes and to test their efficiency across this broad array of stakeholders, you have to have some way of managing that data in an efficient and effective fashion. And the most effective model with which to manage a complex situation, a complex process, is by centralizing that management process. And in order to do that with the number of people who are interested in this, everybody has to be represented at the table in some way or another. There are clearly competing factors. There are competing organizations. There's competition that can't be ignored when it comes literally just to the raw economics, to private versus industry, academic versus private. It's a very, organizations, it's, as you all know, a very complex undertaking. So some sort of a central management site, which we here have called the DROC, is critical. It's really essential to allow this process to move forward in a coordinated fashion on a national scale. And as Jim alluded to earlier, going from local to regional to national is the way of the world. It is the process that the transplant and donation community has been following almost since its inception, even if it didn't realize it early on. And with each technical advance that allows for distribution of organs with longer times available for allocation, it's clear that the data showing that a national system is where this process has to evolve to. So that's the rationale for having a central coordinating area site. How to do it is clearly a little bit up for grabs. It's a very, and that's outside the scope of what we were speaking about anyway, but we did suggest that you could do it by trying simple collaborative multiple organization cooperation or an independent, establish some sort of an independent organization. But what seemed to make great sense to the group was to work within the boundaries established by established transplant endeavors that are already charged with significant oversight in assuring the fair and equal allocation, distribution, et cetera, of organs, and that leads to the OPTN. So in terms of an organization, that it has to that needs to evolve as a priority, as you mentioned earlier. And I think the second part of that, and then I'll turn this over to Jim for his comments, but the second part of that is to make sure that it can operate effectively. And to do that, it has to have the appropriate tools. It has to develop appropriate tools. It has to have mechanisms and processes in place that will facilitate the entire process across the whole endeavor. That is I think that's the compelling reason to have it, to have central oversight and at least a very 30,000-foot, 60,000-foot view of who has to be sitting at the table. Jim?
Yes, that's a good summary. This is Jim Young again, and I go back talking about the history and the movement forward of the OPTN, for example, and what the committee was trying to do. And goal number 6 is sitting at number 6, in my view, because it's the glue that kind of holds everything together. And as Bill mentioned, organizationally moving towards this, we believe, the committee believes strongly, will move the field forward. And we also talked about aspirational views, or as Bill Marks says, visionary views. I think this is where it lies, and this will push it along. Oftentimes we talk about state-of-the-art types of things, and I think what this does is really help us look at what the state of the future is, and then it gives us as players in the entire organ transplant world a concept that we can move to what the state of the future should be. And so a vision of where we can extend things despite the challenges of making this happen. And the critical element of the so-called DROC, Donor Organ Research Oversight Committee, is that it could coordinate across all of the system, procurement distribution systems, as well as the systems built to create guidelines for how we handle a deceased organ donor and how we handle recipients, is going to, in my opinion, positively impact how we move forward. As Bill pointed out, we don't have a template for moving further than Goal 6 right now. That's something that we have to, I think, as a community of organ transplant individuals, we have to go the next step and figure out how to achieve this recommendation. And that would also mean figuring out how to fund the recommendations that have been made. So I think the concept is a critical one. All of the goals are essential to move the idea forward. But number 6, I think, is the glue. Number 5 and 6 are the glue that can keep this sort of thing together.
So this is Lainey Ross. Yes, I would love to add. So the one thing that I really want to emphasize is one of the reasons we thought about the DROC as well as a centralized IRB and a centralized concept of the DSMB is rather than everyone trying to create their own and all that duplication of effort. So this was an idea of by centralizing it, we would make sure that we had the expertise about this rather than requiring every IRB to have appropriate scientific as well as ethical and regulatory expertise. So the whole idea of this was an efficiency issue in order to be able to move this faster. The new federal regulations on human subjects protections that are supposed to be implemented unless anything changes in January of next year has really encouraged the movement to a single IRB, and many institutions have signed on to something called Smart IRB, which makes this even feasible. This is a great time to be thinking about how to centralize it, but to ensure the appropriate expertise. And again, it doesn't have to be a freestanding central IRB. One could imagine sort of creating or having different institutions sort of vie to be the IRB of record that would be the group that would have the expertise that could be relied upon by all the other IRBs. So it's really about efficiency and making sure that we have the appropriate expertise and not assuming that the hundreds of different hospitals all have to redo this. We'll have one wheel.
Thank you for that. Did anyone have anything to add? No? Okay. Next question, can you describe more about what would actually happen during the research on these organs? You know, you mentioned medications and different devices, but what would that actually look like?
Bill, would you like to start with that one?
Research in this case can take on several forms. One form is you could have a device or a molecule that you wanted to test to see what an outcome might be like on a particular organ after it's removed from the body and from the donor, and that could be research that takes place on the back table before it's implanted. And the information as a result of what you have done to that organ may be as simple as data collection postoperatively all the way through to some sort of a biochemical test or an outcome once it's implanted. A second option would be to infuse or to, again, use a device that would manipulate the entire donor. You could have a target organ, say the kidneys, but all of the organs in the potential donor might be subject to being exposed to the treatment. And then you would follow that organ after it is removed, either by following it at some time period afterwards, could be a biopsy of it, or after implantation again. But in that case, you have this confounding issue in which you'll be obligated, in many cases, most cases, to follow the other organs, which I think in the vernacular tend to be called innocent bystanders, but these are non-target organs that were inadvertently or were inadvertently, but recipients of the manipulation that was done to the target organ just by their presence in the potential donor. Extreme is the wrong term. In a significant example, this could the molecule or the substance being tested could include a biologic. This could include nucleic acids. This could include viruses. This could, in its extreme, or it could be a simple molecule or a manipulation of a device. And any of those could be sponsored locally by an investigating institution, be it a private institution or a university, or it could be industry, or it could be a collaboration of both. The key here, though, which is sort of implied in the question, is how do you get this done and still get the organs to be transplanted without interfering? And I think that's the challenge to the community, and that's why, as Lainey intimated previously, we have to make sure that the community doesn't waste time or put any of the other organs in jeopardy as a result of the manipulations that are done. So high degree of coordination, understanding, and planning of what needs to be done for each manipulation in the field is critical. This is going to be done as a non-interfering investigation overall.
Let me see if Jim.
Sorry,
I thought
Jim?
you were finished. Maybe
Yeah.
you weren't. Okay,
I was just going to ask Jim.
Yeah, I agree with that. You know, it's a broad kind of question, and to me, it can range from more radical things that are done in deceased donors where the organs are never utilized. You know, you could see a variety of questions being asked in hemodynamically unacceptable donors. What if we put them all on cardiopulmonary bypass to try to resuscitate the organs and then redistribute them? That's a highly controversial approach and experiment that could perhaps be done. But then it also backs all the way down to answering questions about how guidelines should be written on donor management. Having watched the development of practice over almost 3 decades now, a lot of what we do is, quote, expert opinion, unquote, not necessarily supported by a lot of larger scale clinical kind of trial efforts. And I could see this type of organizational structure really making a major impact both on the science, the research, and even on quality improvement issues. So to me, the types of interventions that could be designed is a panoply of things that just wide open to the clinicians involved in organ transplantation more generally.
This is Lainey. Ross. Yes, I just want to add, I want to emphasize what you just said at the end, Jim, because it's really important for all of us to realize how much variability there is in donor management protocols. And many of them have not been tested. And so, again, just to move the field forward and for efficiency purposes, we have a lot that really can, with small changes, but studies that will require many different sites to be involved, but really to try to figure out which is the best donor management would be just a real step forward, and doesn't involve necessarily new or experimental devices or anything else. I mean, because they're in a sense standard of care at different OPOs, and so that's going to be a really important type of research. The just comparing comparative effectiveness research.
And if I could just add one more thing, I think this is the subtext here has to do with, is it possible And some of the pushback could come from, and it could come literally from the community itself in terms of just a high priority commodity, which is time. So time is expensive to donor hospitals potentially. Time is difficult for donor teams. It's difficult for recipient coordination. And anything, even mundane issues such as conditions of participation from a donor hospital point of view and reimbursement for time in units could become a controversial area, and which emphasizes the reason to have a well thought out central system that has all players at the table and all players understanding the constraints and the obstacles that each of them have to face while attempting to achieve the same goal. So even having CMS sitting at the table in terms of how they're going to craft conditions of participation for the three main groups, including your donor hospitals, transplant recipient centers, and OPOs, is critical to harmonize those if this is going to be effective going forward.
Thanks
Wonderful
for that.
answer, Linda.
We have time for one more question, and then we'll take a couple of minutes for you all to provide any final remarks. So what are the challenges and opportunities for a national organ donor registry? Why don't we have one already?
Lainey, do you want to start?
Well, we have the SRTR has a registry of data about donors and recipients. We don't have a donor registry of the research, and the research we have there is a central registry where all clinical trials are supposed to be registered, but if it's not a clinical trial, we don't have a national registry. This again is an issue of time and energy and effort and trying to get that information in. And even with our clinical trials registry, we all know that the output data, when people are required to put in results, that oftentimes, unfortunately, it's not being done, or there's a large delay, or the information is being put in ways that not necessarily usable by the rest of the community. So this is something that really needs national coordination. Again, going back to the reason that Jim and Bill are so adamant about, the DROC, this National Coordinating Oversight Committee. And it's going to require the community to act as a community and say, yes, we're all in this together and we all think the information is important, and to ensure that we're not duplicating efforts and trying things that have already failed. It's going to require us to keep track of all of this information. To some extent, I don't want to recreate things that already exist, and so one question that we need to think of as a community is, can we use these other systems that are already in place and sort of add on to them rather than creating new systems and therefore having to duplicate the input of data? So how can we modify the SRTR so that we can input that this wasn't an organ which was researched and who are the recipients of target and non-target organs? Can we modify the clinical trials .gov that already exists to ensure that there's an easy way that when you put in the word transplant, all the studies, both clinical trials as well as even other types of research, are being captured and easily located by those who would want to do meta-analyses as well as just understand what's already been tried. So again, the goal is not to just keep developing more and more systems that people have to input data, but to figure out how we can sort of use what we already have and build on it to make for a more robust way of using the data that's already being collected and that will be collected in research models.
I think another part of that, Jim Childress, just add, it seems to me another part of that question is what about a single, unified, secure national donor registry that captures preferences? And Bill or Jim, do you have any reason why we've not gotten any farther along on this particular one?
I think change is hard, and we need, you know, the burning platform concept to get out there and move it forward. And if we got the community of transplanters behind it, I think we could probably get it done.
One problem I know that, if I may, just one quick problem that I know, you know, if we have to get off, I certainly will. Do you want to get off, Dana? Is that what I was hearing Jim say?
No, we can. It's okay if we go a couple minutes over.
Okay,
go ahead.
So one quick comment. You know, I think the National Donor Registry creates lots of challenges. Michelle Goodwin is one of our colleagues on the committee, pointed out repeatedly, and supported by several others, that these are involve states issues as well as, you know, trying about, you know, how to get some sort of how to utilize what's in place already for registry, or for donor, as a donor registry, and to try and understand what the standards might be accepted across the entire nation. You know, to that end, there are some, I guess there are some legal obstacles, at least that's my understanding from what she has outlined. But the short answer is that there should be nothing that would prevent it from happening. The reason it hasn't is, as Jim said, change is difficult. There's already something there that's operating, and to bring about change in a fashion that brings together 50 different groups to agree on a single approach is quite difficult and probably expensive.
Does anybody have any brief final remarks?
Oh, just to thank all those who joined us for this conversation today, and to thank the 3 members of the committee who joined me on this, and just to say that, as others have expressed, the committee felt that this is a very important research with great potential for increasing the number and improving the quality of transplantable organs. And we think that the report addresses some of the challenges as well as some of the perceived and actual obstacles and ways to move forward with the research. But as others have suggested, this will require a lot of effort and cooperation and collaboration.
Anybody else? Okay, I think that will wrap up our discussion this afternoon. Once you exit this webinar, you will be redirected to our report page at www.nationalacademies.org/organ donor research. It's also on this resting slide. All the materials listed will be there, including the slides from today's webinar, and then a recording of this webinar will be available on that page next week. And with that, I'd like to thank all of our speakers for joining us today, and thank you all for participating.